I'm Dr. C. Everett Koop, and I'm very pleased to have the privilege of introducing this film. On the Edge of Being, Physicians with Cancer is a documentary which speaks to us as caregivers. Its humanitarian focus offers sensitive insights into the challenges of patient care, particularly for patients who are terminally ill. The physicians in this program share with us a whole range of experiences. Though we cannot, nor would we want to, put ourselves in their places, they do ask us to be receptive to their suffering and individual anxieties, so that each of us might renew our commitment as caregivers and healers as we practice the art of medicine.
There simply is nothing that will take the place of having been a patient. Your perspective and the way you are dealt with in the world changes abruptly.
I make a transition from a high-functioning human being to a hospitalized patient. It's the hardest time for me. It's the greatest transition. It's a very private time, and it's a very difficult time.
You know, real empathy does involve putting yourself in that person's place, saying, what if this were me? What if this was my mother, my child? And it's hard to do that.
Serious illness, like cancer, is a common denominator of our lives. It does not ask the color of our skin or the language we speak. It does not respect wealth or power. Yet our culture offers us little help in coping with the specter of life-threatening illness. Perhaps no one has better insight into this dilemma than doctors who become seriously ill themselves. In this program, you will hear the experiences of 6 physicians who have confronted cancer. At the time of filming, 2 were cured, 2 were receiving treatment, and 2 had lost immediate members of their families. They spoke candidly with Dr. Norman Straker, a psychiatrist specializing in the treatment of patients with cancer. Their stories point to the many issues facing physicians as caregivers, issues such as the doctor's relationship with the very sick and sometimes dying patients, the need to refocus medical education on the care of the whole person, the importance of providing emotional support and relief from physical pain, anticipating the patient's fear of abandonment, and the physician's own vulnerability to burnout. As care seekers, these physicians experienced firsthand the trauma of critical illness. Their stories are both meaningful and unsettling, and shed light on many of the difficulties doctors face in caring for seriously ill patients.
My own malignancy occurred when I was an intern on OBGYN. It seemed evident that it was probably malignant, and I think my main concern at the time was my wife was pregnant, and I think my main question was and goal was to live long enough to see the child born.
It was the experience of being a patient with cancer that has made Dr. Balfour Mount acutely aware that doctors need to confront the many issues their patients face.
I think it is true, nothing quite so focuses the mind as facing the firing squad, and having been a patient, it has perhaps alerted me to some of the attitudes I may have inadvertently had through my training, conditioning as a medical student, as a young physician. Perhaps so. To be a patient or to have a loved one very sick soon reminds one, I think, that we really are whole persons, and we come as a community. We come with our baggage to illness. And to have experienced that, it's strikingly evident. To be in a setting of walking with the patient and family through that transition zone from where cure is the expectation to realizing that perhaps my time is limited. That transition is extremely difficult, and the medical and surgical oncologists deal with that every day. For those young medical students, doctors, for you and me each day, for our colleagues in all professions, the daily reminder of illness, of death, of being sick, I think is there. And I think we need defenses to help us with that.
My disease process is on the edge. I mean, we follow chest x-rays. My chest x-ray is on the edge. We're not talking millimeters here. We're talking about, I'm on the edge. So
Dr. Peter Morgan is an internist at the State University of New York. He had just completed his residency and accepted a fellowship in hematology oncology when he became concerned about a pain in his right leg.
Just passed the internal medicine boards and thought that it would be an appropriate time to get checked out. I was diagnosed with a right lower extremity synovial sarcoma. Back in October a year ago, I was given 6 months to live. So here I am today, a year later, with a new world, a continuum of my last one, but essentially a new world. You get to choose how you want to approach this new world. And you don't ever have to engage it at all. You can just sit back and just let time go, or you can orchestrate how you want to live again. And that's what I did.
And has it gotten better or worse or the same?
Well, it's stable.
It's stable. I mean,
The truth of the matter is I love medicine. I love the physician-patient interaction. I mean, that's a mainstay of my existence. As soon as I'm out of the hospital, I go back to work. I've gone from getting the IV pulled out of my arm at 9 in the morning to being at work at 11:30. Now, that wasn't a good day for me, but you got to do what you got to do. I live, and then do what I got to do in relationship to this disease.
He was a very outgoing, lively child, very active and self-confident, very warm.
He was interested in how other kids felt already, and he was just a happy kid, really. You know, we look back at pictures of him before he got sick, and he always has a big smile on his face. So, he's a happy kid.
Dr. Julian Offsay practices psychiatry in Hartford, Connecticut. His wife, Jan, is a registered nurse. Their years of medical experience could neither protect nor prepare them for the moment that they learned their 3-year-old son had leukemia.
I don't think it ever crossed our minds that that was the situation that we were about to be in. You know, I mean, I don't know whether our denial was so great or, it really didn't occur to us that that was what was happening. I think because the first blood work, people had said, this isn't leukemia, it didn't look like that, But by the next morning, the minute that we went in for blood work, and the minute that I saw the oncologist's face, I knew that we were in for very big trouble.
When he offered us a 50-50 prognosis, Timmy's prognosis would have been 0 10 years before. So 50-50 was great, but 50-50 wasn't so great for us.
Timmy had, I think, something in the range of 17 spinal taps during the time of his treatment. He screamed and hollered through every single one of them, and it was just a horrible, horrible thing.
He wasn't prepared. There was nothing used to reduce the pain. So if you don't do something to reduce the pain with some kind of analgesic, maybe you can never prepare the child, but at least you can try. So I think that people who are very well-meaning and very concerned are so focused on the fact that they can actually cure you that they don't really think so much about what it takes to do that. And they also don't think about the fact that some of the children are not going to be cured, so that they're going to have all of this terrible stuff done and then they're going to die anyway.
There are some people around the country who are really trying to say, hey, wake up, guys. Kids have pain too. And we can't just act as though they don't have pain, that they don't experience the way adults do or whatever. Kids have pain. And it's important for somebody to think about that. So that I think it really falls on the shoulders of the medical people themselves to be more sensitive to the fact that this is a child. It could be your child. And would you want this done to your child?
You have a chart? He looks great.
For 22 years, Dr. Saul Cohen and his wife Maria shared a medical practice in New York City. Many of their patients were elderly with a variety of ailments, frequently life-threatening. Then, in 1987, Maria developed breast cancer.
My wife, being a physician, knew a great deal about her illness and more or less how she was going to die, because she had seen her sister die, and her sister had predominantly the same illness that she had. Our hopes were dashed one by one by one, and it was inevitable that she would die. At the time my wife was dying of breast cancer, I was taking care of a patient who I had been treating for some 12 or 13 years who was also dying of breast cancer. And I mean, I would go to the hospital and visit her, and perhaps fortunately, she was an elderly woman. I mean, she was in her late 70s, so I think that was a bit more palatable. Had she been in her 50s or 60s, I think it would have been even more difficult. But having the experience I had at home, I was able to listen to her. And I was able to talk to her about death. And since her death, I see her husband periodically, and we basically talk about his feelings and how he's managing.
During the day, I'm in and out. I'm busy, but the evenings are rough.
Yeah, that's the worst part.
Yeah.
Do you sleep all right?
Yeah.
I mean, I know that having gone through the experience I've gone through, that it has made me a much better human being, a much better doctor.
It's as though there was a void next to me. Like I kept looking around. Because Helen used to sit, she never used to say a word. Just quiet. Sometimes she closed her eyes, but never spoke.
But it didn't matter.
The idea that she was there.
Yeah, yeah. My own experience with my wife had an enormous impact on me. I feel I would be spitting on my life if I didn't personally do something in my behavior.
I've spent most of my professional life trying to teach myself and to teach others how it is to be a patient.
For Dr. William Webb, the journey began with a problem all too familiar for many patients: the agony of trying to obtain a definitive diagnosis. When his symptoms worsened, he returned to his internist, who scheduled an MRI. The procedure confirmed a diagnosis of prostate cancer.
And sure enough, the radiologist says, "I think you ought to look at this." Well, there it was. I mean, it was like Gray's Anatomy. I mean, you could see all of the tumor. I was absolutely devastated inside. I've never had anything hit me so personally, and I just felt weak and pain, and the worst feeling I had was how it was going to be to go home and share this with my family. I mean, they had no idea that I was anywhere near this kind of jeopardy. I pretty much, I think, entered the last technological phase of my treatment. In other words, I think we are clearly at a point where the finding the magic bullet or finding the new drug or this kind of thing are becoming less and less part of the picture. Most of my colleagues, if they made any kind of error or mistake with me, they didn't do so because they were doing me any ill will. It was because I think they cared for me. They didn't want to accept the fact that I could be mortally ill, because I was, in a sense, so closely identified with them. And I think that there are many stories throughout the medical profession that will support this notion that doctors cannot be totally objective with other doctors. And this is not out of fear of malpractice. Sure, all of those things are there, but what is the primary thing is the notion that somehow I, as a physician, have failed to conquer death in this situation. And I have, as a result, failed, and therefore I must, in some fashion, move to a more defensive stance.
I mean, his liver function is extremely poor. His synthetic function is extremely poor. We don't know what his metabolic function is. You'll need to...
Several years ago, Dr. Nathan Cherney successfully overcame cancer. His experiences as a care seeker gave him a broader insight into the needs of his own patients and of his responsibilities as their physician.
I was fortunate enough to have a cancer which was eminently curable. And in a sense, I didn't face many of the existential distresses that a lot of my patients are confronted with. My post-operative pain control was a terrible experience. I can vividly recall waking up in the middle of the night in terrible pain and being told that my next injection wasn't due for another 2 hours and I just have to wait it out until then. I hurt terribly. I didn't understand this. I thought there was an injustice and an insensitivity to it. And if anything positive came out of that experience, it was an appreciation of the importance of the care and sensitivity with which I was cared for by the nurses who'd had to try to nurse me through what was, I'm sure, a very distressing experience for them as well. For a long time, the emphasis in medical education has been on what's been so-called the biological model, that doctors have been taught about anatomy, about disease processes, about pathology, and people would come away with a very clear impression that their role as a doctor was to treat diseases. I think that this has been to the exclusion of looking at the notion of the person and the wider notion of suffering. I guess my attitude is fundamentally that I think that patients have a right to be free of pain, and that there is the moral corollary of that is a duty of care that falls upon the medical system to provide that comfort.
Western medicine has traditionally focused on the science of treating disease rather than the art of treating the whole person. But if the role of the doctor is changing, does medical education adequately address this broadened scope?
Maybe that's the biggest problem with medical education. It's what's not talked about, what's not done. In other words, that people tend to avoid the painful, frightening, horrifying experiences. They don't know how to deal with it. Your instructors don't know how to deal with it. And you may go through an experience as a student or an intern dealing with people who are going through awful procedures or illnesses, and nobody talks about it. It's just handled in a very technical manner.
You know, the old medical student pun about being in the pre-cynical and the cynical years, and I think it often is the case that by the time students have completed medical school, that we have conditioned them to be pretty cynical, pretty distanced, pretty depersonalized. What influences our teaching has to do with how, as a society, we see not only illness, but wellness and life itself. There is such a clear expectation in our society that cure, good health, and happiness are part of our constitutional right. And where that's the norm, that's the expectation, then illness is an affront. Somebody made a mistake here. You know, how different from the worldview that sees illness and health as part of the experience, part of the journey.
We spent $801 billion on medical care last year. I don't think anybody in this room feels like they're getting their money's worth. What is the missing ingredient? What I believe is missing is the ingredient of humanity, has slowly but surely drifted away from medicine. And what we need to do, both by personal experience and by our own dealings with our colleagues, is how do we recapture this? How do we get what is really important in medicine back into the experience?
There's another question about that.
Dr. Kathleen Foley, chief of the pain service at Memorial Sloan Kettering Cancer Center in New York City. teaches physicians from all over the world how to better manage pain in their patients. Part of this process is learning to cope with the pain of attachment that many of them experience in ministering to the terminally ill.
We ask that question often of each other, of why we do what we do, why we care, why we think we should think this is an important issue, and also how we can tolerate doing this all the time when you see significant pain, when you see suffering. And I think my own perspective is I think we really do help patients so that you have the gratification of at least relieving their pain. You have the gratification of trying to make it better, although we don't always make it better. And I think we importantly share the responsibility of caring for the patient with a variety of other people, with a team.
Each morning, Dr. Foley meets with her pain fellows to discuss the progress of each patient under their care.
She was diagnosed with lymphoma in March of 91. Her biggest problem was profound sternal squeezing pain, to the point where when I went in to see her, she was the only position of comfort was literally hunched over. If she leaned even back as far as this, she said she had this horrible choking sensation with this really wrenching feeling in her sternum. Her daughter had a recent suicide attempt in the fall related to her mom's illness. Has tremendous amount of difficulty coping with her mom's illness. She said that she's always shied away from psychiatry in terms of it being a label that she found difficult to relate to. But when we also spoke about talking about it, and she says she always feels a lot better when she does speak to someone.
I do think that achieving some degree of trust and intimacy is important. I think, however, for some physicians, it becomes threatening as well, because if one is constantly forming intimate relationships which are then going to be lost, not everyone can adapt to that.
Most doctors, I think, fear failure with the patient, but they can't accept that perhaps the patient has to die. The patient may not respond to their medication. They're unable to offer the patient something else. They're only able to offer the patient the protocol of the day. Instead of sitting down, talking to the patient, listening to the patient, offer them something of themselves.
I think sometimes medical people have been taught, the idea that, empathy to a point, but you still have to remain distant. In fact, some of the nursing staff have been saying that to me, on the floor where I'm working now. And that's true, but I think that can be a cop-out. I think you have to still let yourself really feel, and it means sometimes you're going to feel bad. That, I think that's part of what goes with the territory if you're going to be a sensitive medical practitioner, is that sometimes you are going to feel bad about what's happening with somebody, and that you shouldn't try to block those feelings out. It was the rare nurse, and actually it was one nurse in particular that stands out to me, who was a woman closer to my age, who had younger children, who, was able to say to me, I understand that this is really awful for you. If this was happening to one of my children, I don't know how I could stand it. And that meant so much more to me than these people who were so perky and acting as though, well, we're just sort of going with the program here today. I mean, that somebody was able to tell me, I know you're hurting.
Some of the doctors, they'll make great whatevers, researchers or whatever. They are never going to get the message. And then you can see some young man who doesn't seem to have any special reason, but he's got it. He has that ingredient of humanitarian understanding. And for him or her, it may not be as great a challenge because it comes easier, but it's there. And it's extremely important from a therapeutic point of view.
I think that's an important part after you master the disease part, which you will master during residency, at least to some degree that you can administer care, is to start to evolve your empathy. And that comes from having your hand on the shoulder of the patient when they're going through a test, and let that patient teach you what that test means, or what their illness, what their pain is, etc. And that probably takes a lifelong course to fully appreciate it. I feel at the end of my residency, I started to think about it and started to live that way in relationship to my patients. And I started talking to my other colleagues about it, and then I realized other people were looking at it too, and I said, wow, this might be what it's all about, and being a physician.
For many patients, the prospect of pain can be as terrifying as the disease itself. But doctors can treat pain, even when they can no longer treat the underlying illness.
What we've been stressing is to ask the physicians to start with the fact that they believe the patient's complaint of pain. I mean, that's the cardinal rule, that you start with believing the patient's pain. For the group of patients with advanced disease, oftentimes pain as a symptom becomes the disease. I'm an advocate of teaching patients the concept that they don't have to be in pain.
I was doing well, and all of a sudden, boom, I developed this tremendous pain in my leg. Pain that I didn't sleep for 6 nights and thought that was it. I couldn't come out of my disease. I was in so much pain that I couldn't live for the day. And I thought that was it. So I said to my father, after 6 days of not sleeping, I said, it's time to call Kathy Foley.
Okay. What about your foot? How's the pain been?
Well, I haven't had any pain since I went to not weight bearing on the foot. So
okay, so as long as you're on the crutches.
So as long as I'm on the crutches, I have no pain.
Terrific. Peter has responded, and he hasn't had escalating pain. So his degree of pain relief is enormously impacts on his quality of life, and I think so importantly that he doesn't have to focus on his disease.
There's still all kinds of old attitudes about pain in the hospital. One sees it, for example, if the hospital gets under strain at night, too many patients, not enough nurses, then the nurses have to make the priorities. Are they going to take care of the patient who is suffering with breathing problems, or are they going to take care of a patient who's suffering with pain? All of the terrors that the patient has been dealing with through the day or through the night focus down on, I didn't get my pain pill. But most importantly, there needs to be a spirit of cooperation, collaboration, and understanding that exists from the top of the treatment team down to the bottom layers. And people are working together to try to get this patient improved rather than people acting out whatever their particular conflicts are around their professional identities or their happiness or unhappiness with the system.
In the case of children with critical illness, it is their parents who must advocate for them. This can generate enormous conflict between doing what is best for their child and what is least painful.
Every time they needed blood, which was very frequently, they would do a finger stick, which is really not a small thing. I mean, it seems like it might be a small thing, but I think even most adults are really very afraid of having their finger poked like that. And I was in the room when a lab technician the first week came in to get the blood, and I really thought I couldn't stand it. I mean, absolutely couldn't stand it. And really just thought, he just can't go through that. So we spoke to our oncologist, and we asked him if the blood couldn't be drawn through the Hickman catheter rather than by finger stick. And fortunately, he said yes. He was willing to do it, I think because we were medical people. But if he had not been willing to do it, we probably would have had a big fight.
I think the most difficult thing as a parent is to be barraged by your child who doesn't want to do what you know they have to do. And it's harder and harder to keep asking a child to do that when you see that their survival is really not going to be prolonged, when you see that the outcome is really not going to be there. And your terrible ambivalence of attempting to go for the gold at the time that you know that you're not going to in any way reach that. I think this difficulty for parents is overwhelming.
Now, if a patient with cancer has pain, the caregiver and the patient and the family member should not be satisfied, and they should be always asking questions as to why, and we should just never accept the presence of pain without feeling what more can we do?
The caregiver's most awesome responsibility after the diagnosis is helping the patient confront the last phase of the disease. By guiding the patient from health to illness and from illness to death, the doctor can forge a bond of support so needed on this painful journey.
But the dialogue is so difficult, because how do you sit with someone that you've taken care of and say, it doesn't look like anything's working? We often can say that, but that's very different than saying you are dying. And we often don't say that to patients unless they ask us, and even when they ask us, we often dance around the topic because we don't know how to do it well.
I think I could have benefited, and I think most doctors could benefit from some spiritual training, because it certainly is important that at that state that we function as a rabbi or a priest, even though there may be a rabbi or a priest around. I think the patient may look more toward the doctor.
To talk to patients who are dying. Doctors are often doing this day in and day out, and everyone brings to it their own experiences and their own view of dying and their own perception of the patient. And the fact that we can begin this dialogue with patients, I think, will make it easier for us.
I'm thankful I'm here. I really am. I'm going to be there for a very long time. And
Where's
being
there?
here, huh?
Where's there?
Over the mountain. I'm going to be up in golf heaven somewhere. But I really, I'm not ready to go.
The wonderful thing about Adelaide has been her remarkable adaptability. She knows that there's enormous uncertainty in terms of her long-term survival, and she's aware that she will ultimately die of myeloma. I think firstly she needed to be liberated from her pain.
I was ready to give up. I really was ready to give up, and you promised me, no matter what happened at the end or whatever, that I would never be in pain. You would see to it that I would never be in pain, and that's really kept me going.
I get the strong impression that you've gone from a situation where you felt that you were dying of cancer to a situation now where you're very much living with your cancer.
Absolutely. Absolutely.
I have no expectations of curing Adelaide, and I will derive an enormous sense of satisfaction from knowing that her life has been so much the richer, not only for her but for her family as well. And when they look back on this experience, it won't be with this feeling of terror and dread and horrendous memories, but they'll look back on this period knowing that they were able to continue to maintain a life of worth despite living with a life-threatening and ultimately terminal disease.
I may be a person who, for whatever series of reasons, don't feel comfortable taking care of people who are dying. Fine. But then I need to recognize that and involve others in helping my patients who are comfortable in that situation. Not feel guilty about it. I got enough I don't need more things to feel guilty about.
The amount of suffering that some of these patients can bring into your life, or that they carry with them, is enormous. And to try to take all of it upon one pair of shoulders is really what can precipitate burnout. I'm a very, very strong advocate now, or I've learned to become a strong advocate of sharing the burden of care for these people. I think that their needs are so diverse as to require a very broad spectrum of expertise. I'm not a social worker, I'm not a psychiatrist, and I'm not a clergyman.
Geez, I'm one person. If said before, if the high divorce rate doesn't teach me anything, it teaches me I can't be all things to even one other person, let alone patient after patient after patient. So I need a team.
Come down here. If sometimes we just sit down and talk to our colleagues or the students talking to their peers, just mentioning that we all feel that way. We all have these problems. We all have these inadequacies. Will allow us to go ahead.
Sometimes doctors, however unintentionally, distance themselves from patients who do not respond to treatment. These patients can feel that they have somehow failed their doctor and have now been abandoned.
I think it's such an important issue that we're not going to abandon them, that we're not going to minimize their symptoms, and that we should be responsible in providing them with a real continuity of care. The hardest thing we see is when a patient has been cared for by a physician for years, and then the disease and its treatment have failed, and the patient feels that that doctor's abandoned them and triaged them off to someone else.
The biggest frustration that I see in these angry kinds of interchanges is that the doctors or in this case, the nurses and the patients really are not communicating with each other. They are communicating about something else that is, that looks like they're communicating. So it's important to find out what it is that is the real issue. And the real issue, 99% of the time, is do you care about me? And do you really care what happens to me? And are you genuinely, do you want to help me in some kind of way?
But I think the fears also are fear of isolation, fear of abandonment, fear that my doctor won't have a bed for me because he says there's nothing more that can be done. Or fear of a bed with a parking meter on it. In other words, if I get in there, they're not going to want me in very long holding up that because I'm blocking a bed. Fear that my relatives won't visit me anymore. Fear that you know, the nonverbal fear that we project when we go in the room. The patient who said, you know, my wife used to kiss me goodbye on the mouth, and then I noticed that she kissed me goodbye on the forehead. Then a week or two later, she was squeezing my shoulder, and then she squeezed my hand, and you know, earlier today when she left, she wiggled my toes from the end of the bed. And very perceptibly, he was picking up the progressive distancing that his wife unquestionably wasn't even aware of.
There are 5 essential skills or qualities that one needs to have to be a good doctor, I think. A doctor needs to have cognitive skills. He needs to know his business of medicine. He needs to care. He needs to have communication skills. He needs to have the conscientiousness to follow up on things, and he needs to have a curiosity to pick up on issues and to follow them through, to want to know what's happening in the family, to know how you're feeling, to want to know how you're coping. Take away any one of these qualities and you're left with suboptimal medicine. These sort of things aren't qualities that you expect in a good doctor. These are the sort of qualities that we have a reasonable right to expect from every doctor.
Many, many, many times I think in my mind consciously about how Timmy's oncologist would call us back. And when Timmy was terminal, and it was time to let him go, because you can always do something nowadays to prolong somebody a little bit more. You know, he could have had another blood transfusion or something like that. It was our confidence in his oncologist. I don't think there was anybody else on earth who could have said to me, well, this is it, that we would have just accepted it. When he finally said, look, you know, you have to let him go, it was the year and a half of trust that led us to have faith in him.
I think the doctor's role is to be a catalyst for healing. And I think we have to see healing as embracing body, mind, and spirit. I think we have to realize that people can die healed.
Only when healing occurs can we again make our way forward toward a sense of renewal after the loss of a loved one, or a meaningful existence within the shadow of death. Ultimately, each of us must find our own way there.
It was almost 3 years before we felt like we were again kind of a regular family unit, that we were enjoying things again in a different way. And it was around that time also that we made a decision that we wanted to have another child. And did go ahead and adopt a baby from Romania. The boys were very opposed to us adopting Marissa, in fact. I think largely because they felt it was a betrayal to Timmy's memory. They saw it as trying to replace him, and they didn't like the idea that we were doing that. In fact, though, they have been able to really see that she is not him, that she occupies a different place in the family, and that she's, really brought a good experience to them as well.
But I think that it wasn't until we adopted her, which was 3.5 years after Timmy died, that I would say I really felt like I came back to life. And I think it really was something very powerful like that, like having a new baby that made a difference.
To pull us back into...
To pull us back into life, so to speak.
I was fortunate. I mean, I had an incredible wife who prepared me for her death, as she did the rest of the family. I felt ennobled by my experience because I felt I did everything one human being could do for another human being. I felt our love grow through this situation. Her courage gave me courage, and we could continue, and then we went to another level of more courage and more love, and we went higher and higher and higher until I really feel we touched God.
And maybe the answer is that somehow the experience of needing to go, that this is part of life, of needing to go through the experience of being supported through something that is horrendous and that takes something valuable away from you. I don't know the theological explanation for these things, but in a very fundamental way, I've felt God's presence with me like I've never felt it before. And I woke up one morning over this week, and I said to the nurse, I feel calm today. I had some kind of an experience through the night that led me to some sort of calmness that I feel. And I believe that's real. I don't think that's just a psychological reaction on my part. And I believe that's directly related to the fact that somehow I'm beginning to put together my position in relation to my own life. Maybe this is what people do when they go through this kind of thing.
When you are sick, you think, well, I can't give anything because everyone's giving to me. But that's not true. There's a flip side of that. You can teach and share, and doing that the right way is a tremendous gift. Before all this happened, I don't watch TV, but somehow there was some documentary I saw somewhere. It was about gorillas. And I guess the polio virus or some neurotropic virus was introduced into this gorilla colony. And so they showed you this big gorilla climbing up the hill with a paralyzed leg. And I said, well, God, if I ever have some problem with some disease, I'm going to do the same way. I'm going to have that gorilla's mentality, which is basically to live his day. He just cared about where he was getting his next banana, and he was climbing up the hill for survival. And I think that's my relationship to my disease. I mean, it's just you just go on. I mean, if this leg I don't walk on it, but if you took my other leg too, I would still just continue to walk with my crutches and get to my job and get to the next place I gotta go.
We're on a voyage, all of us. What we need is people to be in community with us on our voyage. People who will value me as a person. And I'm valued if people care about what I'm experiencing. And that's, of course, the problem. As caregivers, we think we have to have the answers. We don't have to have the answers. We don't have the answers. But if we're there to share the questions, that's what the person wants, needs. And of course, that's the paradox. We're not focusing on dying, we're focusing on living, and the quality of living. And we're really all in the same boat, exactly in the same boat, whether I think he's going to die today and she's going to be grieving tomorrow and I'm going to be going on. Boy, we're in the same boat.
As the writer Anatole Broyard wrote just before his death from cancer, not every patient can be saved, but his illness can be eased by the way the doctor responds to him. In learning to talk to his patients, the doctor may talk himself back into loving his work. He has little to lose and everything to gain by letting the sick man into his heart. If he does, they can share, as few others can, the wonder, terror, and exultation of being on the edge of being.